And I know I'll be joined by Dr. Lisa Dubrofsky momentarily. There she is. Hi, Lisa.
Hi. How are
you? Can
you?
hear me okay? Great.
Great to hear about all the amazing work you're doing.
Thank you so much. And thank you, of course, for joining us tonight. So pregnancy and PKD is the session that we're going to jump into right now. Lisa Dubrofsky is a nephrologist and hypertension specialist at Women's College Hospital and Sunnybrook Health Sciences Center in Toronto. And she'll be discussing considerations for PKD patients prior to and during pregnancy. Topics will include pregnancy planning, risk factors, medications, kidney function, and pre-eclampsia. Lisa Dubrofsky is a nephrologist and hypertension specialist, as I mentioned. She is an assistant professor in the Department of Medicine at the University of Toronto, and her research interests are in improving quality of care for people with complex hypertension and people affected by hypertensive disorders of pregnancy. Dr. Dubrofsky, thank you again for joining us tonight, and I look forward to hearing your presentation.
Thank you so much. It's great to be here.
Hi, everyone. It's really great to be here today. Thank you so much for having me. My name is Lisa Dubrofsky, and I'll be speaking about polycystic kidney disease and pregnancy. I do not have any conflicts of interest to disclose for today's talk. I'll be dividing the talk in two main sections. First, we'll cover some of the considerations to come up prior to pregnancy, and I'll cover some of the medications that may need to be changed or stopped prior to pregnancy. We'll talk about some of the individual risks and how you can speak with your healthcare provider to better understand your individual risks prior to pregnancy, and how we can try to lower those risks by optimizing risk factors prior to pregnancy in some cases. And we'll make sure that going into pregnancy, you have a good plan for how you're going to be followed during pregnancy. And then I'll touch on some of the considerations that come up when we're following people with kidney disease during their pregnancy. So we'll speak about hypertensive disorders of pregnancy, one of which is preeclampsia. We'll talk about the risks to your kidney function during pregnancy, as well as urinary tract infection risk during pregnancy. I'll use some short forms for some of these terms. So you can see CKD is chronic kidney disease, BP is blood pressure, PKD referring to polycystic kidney disease, and UTI referring to urinary tract infection. So what about when pregnancy is not desired? So I just want to start off by saying that there are safe birth control options for patients with chronic kidney disease across the CKD spectrum. And there are some options that may be less preferable for people with high blood pressure or people with kidney disease. And just to remind everyone that if a woman is breastfeeding, even if she's not menstruating during that time, she still can get pregnant while breastfeeding. And breastfeeding is really not considered a reliable way to avoid pregnancy. This table shows some of the different contraception options, and going from top to bottom, the options at the top of the slide are considered more effective at preventing pregnancy versus the one at the bottom of the slide may have more risk of pregnancy while using this form of contraception. So the most effective contraception method is for the male partner to have a vasectomy, or for the female partner to have a tubal ligation, which sometimes can be done at the time of a planned C-section if the family feels that the family is complete at that time. Another very reliable form of contraception is an intrauterine device, sometimes referred to as an IUD. There are different forms. People can have copper IUDs or hormonal or progesterone IUDs. Both of those are considered safe for people with hypertension or high blood pressure or people with kidney disease. And those are generally considered very reliable forms of contraception. And one of the advantages is that once it's inserted, really a woman doesn't need to remember to take any medicine or really worry about it. Progesterone injections can be given once every 3 months. They may decrease bone mineral density. So in some people with kidney disease who require steroids, that may be of concern. There may also be an increased risk of blood clots with this type of contraception. restoration of fertility for an IUD, for example, is quite quick, or for other forms of contraception. But the progesterone injection may make it take longer for a woman to become pregnant. So if a pregnancy is desired in the near future, this is not the optimal form of contraception. There's many forms of estrogen progestin combinations. So it can be a pill, a ring, a patch. These forms of contraception are often not ideal for women with kidney disease. The first reason is that many people with kidney disease have high blood pressure, and this form of contraception, when there is estrogen in the contraception, that can raise blood pressure. In people with proteinuria, the estrogen pill in particular can increase the amount of protein in the urine. And this form of contraception is not generally recommended for people who have an increased risk of heart problems or smokers over the age of 35. And there is an increased risk of blood clots associated with this type of birth control. The progesterone-only pill is often a good option for people with high blood pressure or kidney disease. There's no increased risk of blood clots associated with this type of contraception, but it does need to be taken consistently within a 3-hour window each day. And likely that does contribute to why it's less effective when we look at all comers in preventing pregnancy, because there is a consistency required to taking that medication. And fertility is restored very quickly upon stopping the birth control. And then barrier methods are, of course, an option, but there is a high failure rate associated with barrier methods of contraception. So moving on to pregnancy and pregnancy planning. So I always recommend that all patients who are taking any medication speak with their physicians about what the plan would be in pregnancy for their medications. And in particular, in people with kidney disease, there are medications that we prescribe that are not safe for use in pregnancy. So they're not safe because they can lead to fetal abnormalities or problems with the baby if mom is taking these medications during the pregnancy. And commonly prescribed medications for people with kidney disease include these medications, which we call ACE inhibitors or ARBs. So ACE inhibitors generally end with the last 4 letters pril. So these are medications like perindopril, ramipril, enalapril, and there's many others as well. And the medications that are referred to as ARBs generally end with sartan. So that's medications like candesartan or irbesartan or telmisartan. And of course, there are many others. So these medications really should not be on board during pregnancy, in particular after 8 weeks of gestational age, because they have been associated with really quite severe abnormalities in the fetus. Other medications that are potentially commonly prescribed to people with polycystic kidney disease include tolvaptan and statins, which are generally not considered safe in pregnancy and would not be continued during the pregnancy. Just of note, in some patients, if there's really a lot of protein in the urine, we don't necessarily want to withhold these beneficial medications for a long time if pregnancy is maybe not going to occur right away. And so in some patients, we may suggest continuing on certain medications and then really monitoring for pregnancy closely. So monitoring for irregular periods. Sometimes we actually do monthly pregnancy tests to ensure that the patient is not pregnant, so that the medication could be stopped in that scenario. And so, there's many other medications that people may be taking, and sometimes it's a matter of just changing to a different medication or of having a conversation with your provider about the risks and benefits of continuing or stopping different medications. So it's a good idea to always have a plan in advance. If somebody's blood pressure is difficult to control and that they're taking multiple medications to control blood pressure, then usually I do suggest changing to pregnancy-safe medications prior to the pregnancy so that we know what regimen the patient needs to be on, that they tolerate these medications well. And we do have lots of safe blood pressure lowering medications that have been used for many years in patients who are pregnant. So that includes labetalol, nifedipine, long-acting, methyl-dopa, hydralazine, and there are some other options if these are not sufficient. And so the downsides of these medications is that methyl-dopa and labetalol does need to be taken multiple times per day, as well as hydralazine. So that's why sometimes these are not medications used as often outside of pregnancy, but they're safe for the fetus and usually quite effective. And in most patients, we really don't have a problem controlling blood pressure prior to or during pregnancy with these medications. I'm certainly not an expert on this, but I did want to mention that in people who have polycystic kidney disease, pre-implantation genetic diagnosis, so where they check to see if there is the PKD gene in the embryo, this can be an option. And then the selected embryos would be implanted versus, via IVF. So I just want to mention that this is something that's available. And if this is right for your family, then it's a good idea to get more information. Your nephrologist may or may not have a lot of information about this, but a geneticist certainly will, potentially fertility experts, etc. And then it's always important to get the usual pre-pregnancy testing that every patient should have. And so it's recommended to go see your primary care provider, make sure your blood work is up to date. Sometimes immunizations need to be updated prior to pregnancy. And so making sure everything is okay from that point of view is a good idea. Anemia, particularly iron deficiency anemia, is very common in women in general. Probably more common in people with kidney disease. And so it's a good idea to check and see where your hemoglobin is at, see if your iron is low, and start supplementing iron before pregnancy. I always tell my patients the baby eats all of your iron during pregnancy as the baby's growing. And so iron deficiency in pregnancy is very common. It can make women feel bad, increased fatigue and things like that. And so it's a good idea to try to optimize these things prior to pregnancy. And then again, in all women, it's recommended to take folic acid prior to pregnancy. And we like it to be on board for about 2 months prior to actually conceiving. And so, of course, we don't always know when that's going to happen. And so if there's any chance of pregnancy, if somebody's not using reliable contraception, it's a good idea to be taking folic acid every day. And this is going to be included in pretty much every prenatal vitamin, but it's always a good idea to check. So this can be purchased over the counter. And if for some reason you don't want to take the prenatal, or there's something in the prenatal that's not being well tolerated, for example, there's sometimes some iron, you can actually purchase just the folic acid on its own. And sometimes, especially at the beginning of pregnancy, if someone's experiencing nausea, vomiting, then just taking the folic acid alone can be better tolerated than taking the whole prenatal. And then it's good to have a plan where you're going to be followed. And so I'm going to be speaking in a little bit about some of the risks in pregnancy, but it is recommended to follow with what we would call a high-risk obstetrician. And so these are obstetricians that are used to following patients with high blood pressure, potentially with kidney disease and other medical problems. And depending where you live, there are some centers that may have a nephrologist and an obstetrician that work together in what we call a shared care clinic, where you would go see the nephrologist and the obstetrician at the same time throughout your pregnancy. There are other centers where there's internal medicine doctors who specialize in pregnancy, who will see you throughout the pregnancy. And in some scenarios, you may continue to follow with your usual nephrologist and then also follow along with your obstetrician. The reason to be followed in one of these higher risk centers is that they have access to more testing, more monitoring, and they're used to following people with medical conditions. And then, I just want to start by saying, before I get into some of the risks in pregnancy, that it's important to note that really every patient's individual risk for complications in pregnancy is going to be different. And so I'll talk about some of the factors that increase the risk and what the risks are in general. But I really encourage you to speak to your nephrologist, to your primary care physician, to your obstetrician potentially before pregnancy about what your individual risks are. And so I'm not going to be really covering, the obstetrical risks in particular. So if there's a risk of a short cervix, for example, things like that, I'm not going to get into. I'll speak more about the medical risks, but depending on your obstetrical history, your gynecological history, there of course may be other risks that I'm not going to touch on today. And then we'll talk about some of the ways to reduce risks for complications in pregnancy. So in terms of patients with chronic kidney disease, I usually divide the risks into three main areas when I'm speaking with patients. So the first thing is that pregnancy does put a patient with kidney disease at risk of their kidney disease actually progressing or the kidney disease worsening because of the pregnancy more than it would have worsened over that time period if the woman were not to have become pregnant. And so we'll talk about that in detail in the upcoming slides. We'll talk about the risks related to hypertensive disorders of pregnancy or preeclampsia, and the fact that people with kidney disease are at an increased risk of developing these disorders and what that means for mom and baby potentially. And I'll discuss a little bit the risks to the baby, which are really often tied into the hypertensive disorders of pregnancy, but not always related. So first we'll discuss the risk of kidney disease progression. So there's many factors that influence how likely patients is at risk of their kidney disease worsening during the pregnancy. So for some people, that risk is relatively low, and for some people, that risk is actually much higher. And so that's why I think it's really important to take this information and then discuss it with your individual nephrologist to better have an estimate of your individual risk. And sometimes I will say that there are preconception counseling with specialists, so either with obstetrical nephrology specialists or internal medicine doctors to really quantify your risk in a very detailed way if your individual nephrologist is not experienced or equipped to do that for you. So the factors that we think about are, number one, the baseline kidney function. So if a patient has very mild kidney disease, then the risk of their kidney disease worsening in pregnancy is actually relatively low. If a patient has more advanced kidney disease, then the risk of the kidney disease getting worse in pregnancy is higher. The second factor is the amount of protein in the urine. So similar to the kidney, the degree of kidney dysfunction, the degree of the amount of protein makes the risk of kidney disease progressing higher. So if there's more protein, the risk of kidney dysfunction developing more rapidly in pregnancy is higher. And then the baseline blood pressure. So if blood pressure is very well controlled prior to pregnancy, that's a very good thing. If blood pressure is poorly controlled prior to pregnancy, that does increase the risk that the pregnancy is going to lead to more damage to the patient's kidneys. Some of these may actually be modifiable. So having good blood pressure control going into pregnancy is a good prognostic factor. So that's something that you can potentially control. And sometimes lowering the protein in the urine can also be managed. So with specific medications, which we know help lower protein in the urine. That may be more relevant for other causes of kidney disease, but I thought I would include it here because some patients with polycystic kidney disease may have protein in the urine, and also patients with polycystic kidney disease may have other things going on like diabetes or high blood pressure contributing to their kidney disease. So it's tough to put numbers in general. And like I said, it really is a risk that needs to be individualized for each patient. But to try to give you an idea, if someone has mild kidney disease and pretty preserved kidney function, then the risk of the kidney disease actually progressing from the pregnancy is relatively low, something around less than 10%. However, if the patient is in later stages of kidney disease, so usually we refer to a GFR under 30 in this, then the risk of kidney progression is higher, and it can be somewhere between 30 to 45%. And this, exists along the spectrum, and the more severe the kidney disease, the more likely that the kidney disease will progress. And in some patients, this may actually mean that they need dialysis or they need a kidney transplant earlier. And it could be somewhere between 1 and 5 years earlier than we would otherwise expect. And so if we see a patient who has, quite advanced kidney disease with a GFR in the sort of 20 range and has protein in the urine and has high blood pressure, we would tell them that there is a substantial risk that they might require dialysis during the pregnancy. And I think it's important to be informed about this, as it may change, someone's decision about whether to have a pregnancy or not. I just want to, say that this is for all comers with chronic kidney disease and really not necessarily patients with polycystic kidney disease. There are some risks to the baby that are increased as a function of having kidney disease. So there is a higher risk of having a small baby or the baby coming early compared to people without kidney disease. And again, these risks exist along a spectrum, and the more severe the kidney disease is before pregnancy, the higher these risks are. So I'll switch gears a little bit to hypertensive disorders of pregnancy. So this is really a spectrum of diseases, and I've put lots of words up here, and I'll try to go through it and explain it slowly. But in some patients, hypertensive disorders of pregnancy just means that they develop hypertension or high blood pressure during the pregnancy that didn't exist before the pregnancy, or perhaps that got worse during the pregnancy. Preeclampsia is generally when a patient has high blood pressure, but also another problem related to the high blood pressure. So sometimes that's an increased amount or new protein in the urine. Sometimes that's problems with liver tests. Sometimes that's problems with fluid on the lungs. It can really be a variety of different features. If a woman has high blood pressure in pregnancy and actually has a seizure from that, then that's called eclampsia. And that is very rare, but as you can imagine, very serious. HELP syndrome, it refers to a constellation of lab test abnormalities, so a low hemoglobin and low platelets, that is again related to this syndrome of high blood pressure and really blood vessel damage. And so it's known now that these preeclampsia or some of these disorders develop because there's these factors that are released from the placenta that can damage the mother's blood vessels. And we've actually recently been able to identify some of these factors. And in some centers, we can even test for them to help predict if a woman is likely to develop preeclampsia in the subsequent weeks. So there's really a lot of new information being found by the medical community with regard to preeclampsia and potentially new treatments in the future. But right now, the treatment for preeclampsia, if it is severe and is causing the mom to become sick, is actually to deliver the baby, because that will make the mother's disease improve. And unfortunately, that means that often the baby has to come early and maybe small and may need more intervention like neonatal ICU care. And so this is something that can happen to people who don't have any medical abnormalities at all, no medical problems. But in some people who have underlying medical problems, preeclampsia or hypertensive disorders of pregnancy can occur more frequently than in the general population. So these are some of the risk factors for hypertensive disorders of pregnancy. And some of them, of course, we can't control, most of them. But I've put them here just to sort of get an idea. If you have multiple risk factors, your risks may be higher. So having a personal history of preeclampsia in a previous pregnancy does put a patient at an increased risk of this happening again. Maternal age 35 is considered a risk factor. It being a first pregnancy is considered a risk factor. A twin or a multi-fetal gestation pregnancy, and having a family history of preeclampsia. And then some underlying, chronic illnesses or diseases do put people at an increased risk. So that includes diabetes, having high blood pressure prior to pregnancy, and then having kidney disease is considered a significant or a major risk factor for this disease. SLE here refers to lupus. APLA is a rare disease sometimes associated with lupus called antiphospholipid antibody syndrome. OSA refers to sleep apnea, and being overweight or obese are risk factors for hypertensive disorders of pregnancy. We talk a lot to our patients during the pregnancy about the signs and symptoms of preeclampsia, and we really monitor for preeclampsia and for these complications so that we can identify it early, address it early, and make sure that that really mom and baby are okay and that baby gets delivered at the time that is necessary if that does occur. And so often preeclampsia will prevent with worsening or new onset high blood pressure. And so your doctor is going to monitor your blood pressure very closely in pregnancy. And in many people who have underlying kidney disease or underlying high blood pressure, we do recommend home blood pressure monitoring as really an adjunct to the clinic blood pressures. Preeclampsia can present with blood test abnormalities, and so we really monitor blood work quite regularly. In our clinic, in patients with kidney disease, we often check blood work about once a month. And so we're really looking for progression of kidney disease, but also for any signs of early preeclampsia. And the baby is monitored more frequently than would otherwise be done potentially in a low-risk pregnancy. So that may mean more ultrasounds or more testing for the baby. And we always remind patients about the symptoms of preeclampsia. So we tell them to go really directly to triage if blood pressure is very elevated, or if they have any symptoms that are new, like headache, visual changes, pain in the upper abdomen, leg swelling, chest pain, shortness of breath. And some of these symptoms can be normal in pregnancy. Sometimes, some degree of shortness of breath or some degree of swelling can be normal. But, people are followed very closely. If there's any concerns, then they're seen. And we really just want to make sure to diagnose problems as they arise quickly. So there are things you can do to help lower your risk of preeclampsia. And so there are some risk factors that we would call modifiable, which means that they can actually be adjusted or changed or lowered with action. And so it is really important to try to obtain a healthy weight prior to pregnancy. And so this will impact potentially the risk of preeclampsia, because we know that being overweight or obese is a risk factor for preeclampsia. In addition, we know that people who've had preeclampsia in a previous pregnancy, if they return to their pre-pregnancy weight, so they return to the weight that they were before their pregnancy, then going into their next pregnancy, that will help reduce their risk. Versus if they keep on weight from their previous pregnancy, that does increase the risk of preeclampsia reoccurring. And so, of course, this is very challenging, and I really urge you to speak to your primary care provider, speak to other healthcare providers, speak to your nephrologist, and really try to get support that you need. Whether it's speaking with dietitians, speaking with social workers, whether it is taking medication to help with weight loss, or bariatric surgery or other weight loss programs. This can really be an important modifiable risk factor for pregnancy. And there is some data that exercising during pregnancy can help reduce the risk of preeclampsia. And of course, that's not possible for everyone, depending how you're feeling during pregnancy, but for some women, that can be helpful. There's really pretty good data now that aspirin during pregnancy is an important way to help reduce the risk of preeclampsia. And so generally, we recommend 2 baby aspirins taken at night. And I just want to clarify that I'm not suggesting anybody start this before speaking with their healthcare provider. We want to make sure that the placenta and everything has implanted okay, and that there's no increased risk of bleeding with the aspirin. So generally, we wait until 10 to 12 weeks. And then as the placenta is implanting, if the aspirin is on board, that has been shown to help reduce the risk of specifically preterm preeclampsia, which means that the preeclampsia is occurring early. And really, that is what we want to try to avoid, because that does come with increased risks to the baby being smaller and coming earlier. And so it's really important that aspirin gets started before 16 weeks if it's considered safe to do so for your individual case. And for most patients, they are able to safely start aspirin. And again, it is safe in pregnancy. We stop it at around 36 weeks, so it's not usually on board at the time of delivery. If a patient has to deliver early and aspirin is on board, then that's generally okay as well. And so one other way to reduce the risk of preeclampsia is a calcium supplement if you're taking a low calcium diet. I didn't include on this slide, but there is some recent data actually that having good blood pressure control can help reduce the risk of preeclampsia. And that data is not specific to people with kidney disease. It was actually in people with high blood pressure who don't have kidney disease. But in general, we do target blood pressure in pregnancy. So, I mean, again, I want to be careful with providing numbers because we don't have, a lot of data on risks of complications, specifically in people with polycystic kidney disease. And so this is, a relatively small study where they looked at people with polycystic kidney disease and they compared their risk compared to people who had simple cysts. So this is just 92 patients with PKD versus 150 patients who had simple cysts on ultrasound. And there was, as expected, a higher rate of complications in the mother in the people with PKD. And what these complications were was more high blood pressure or worsening of previous high blood pressure, more swelling, and an increased risk of preeclampsia. So it's very, I think, complex decision to think about when pregnancy may be right for you. And obviously, there's so many other factors aside from kidney disease that may determine this. But in terms of thinking about your kidney disease, I do think it's worth, at least noting that the risks of preeclampsia, of early delivery, the risk of kidney disease progressing because of a pregnancy, those risks do increase as kidney disease worsens. And so that may, be a consideration to think about, having a pregnancy earlier if that's right for you. I do want to mention that we have had, many healthy babies delivered on dialysis, on people who are on dialysis, so rather the mothers on dialysis. And, this is considered high risk, though, and this does require really intensive dialysis. And so this doesn't come up very often for people with polycystic kidney disease, but in patients with other forms of kidney disease, sometimes they are on dialysis already. And for, one reason or another are not going to have a kidney transplant, during the time that they want to become pregnant. And so we do continue dialysis. We do 36 hours of dialysis a week. So that's very different from the typical 12 hours that's done for most patients. And there's, a lot of monitoring, as you can imagine, for these patients. The other option for people with very advanced kidney disease is to have a kidney transplantation if that's available to them. In general, we recommend waiting about 1 year after the kidney transplant, being on medications that's safe in pregnancy, and then going on to have a pregnancy after that. And of course, these pregnancies still do have increased risks of preeclampsia and of many of the things we talked about today, but also we've had many good outcomes, and there's many good outcomes reported. Some patients with PKD may have, really tight or low blood pressure targets outside of pregnancy. We don't target such low blood pressure targets during pregnancy because of the theoretical risk that we're going to reduce the blood flow to the baby in that context. And so generally we try to keep the top number or the systolic blood pressure between 120 and 140, and the bottom number or the diastolic blood pressure between 70 and 85. And lastly, I just want to mention that there is an increased risk of urinary tract infections in people with polycystic kidney disease in general. And we worry about urinary tract infections in pregnancy because of changes to basically a woman's anatomy and the way the sort of muscle and connections are between the bladder and the kidneys, there is an increased risk that bladder infections, which are usually, not that serious and referred to as UTIs, there's an increased risk that those can become kidney infections, which actually is very serious and can lead to fever and really a woman being quite unwell. And so we want to try to prevent UTIs or catch UTIs very early, or even catch bacteria in the urine, even if the woman doesn't have any symptoms, very early in pregnancy. And that's true for all pregnant women, but maybe more relevant for people with PKD who are at an increased risk of urinary tract infections in general. And so what do we do for this? We make sure that we are monitoring urine tests frequently and looking for bacteria in the urine or signs of bacteria in the urine frequently. We advise our patients to always let us know if they have any symptoms of urinary tract infections. Sometimes, it's vague or it overlaps with symptoms of pregnancy. So, the majority of pregnant women at some point in their pregnancy will report urinary frequency, specifically if the baby's head is lying right on the bladder. But, if somebody has these symptoms, we just check and make sure that it's not from an infection, versus just a normal finding in pregnancy. And if there is bacteria in the urine, even if the patient doesn't have any symptoms, we do treat with antibiotics because we want to prevent, again, these bladder and kidney infections in pregnancy. There is this phenomenon reported that with the estrogen, which increases in pregnancy, this may lead to an increase in liver cyst growth. And this may lead to increased abdominal pain or fullness in patients with PKD who are pregnant. And, it's a complex conversation in general, as you likely know, about whether to look for aneurysms of the brain in patients with polycystic kidney disease. Generally, we do it in women who are planning pregnancy or even at the start of pregnancy. And the reason is because if there is a very large aneurysm, then we would want to get our colleagues in neurosurgery, their opinion, and we would want to get our colleagues in anesthesia's opinion to make sure that the method of delivery, whether it's vaginal or C-section or induction or not, et cetera, and make sure that it's safe with regard to not triggering any problems with the aneurysm. But this is overall not a frequent issue. After pregnancy, so we do encourage breastfeeding in our patients, and all the blood pressure pills that we use during pregnancy are generally okay for after pregnancy. So that's labetalol, Adalat, and methyl-dopa are safe in breastfeeding. And there are some other options that we can add on. So not all of the ACE inhibitors and ARBs, but a couple of the ACE inhibitors are considered safe in breastfeeding, and we do use them. So that includes enalapril and quinapril. We always recommend discussing contraception options during pregnancy or after pregnancy if that's relevant. And then, we really encourage patients to make sure that they're getting the usual care support that really needs to be offered to all new moms. So there's many challenges with breastfeeding, making sure you have support with that regard. And of course, having good mental health support. So we know that in the postpartum period, there's very, frequent rates of depression and anxiety, and we want to make sure that you're connected with resources if that occurs after pregnancy. And then, generally you follow with your obstetrician until about 6 weeks after the pregnancy. Blood pressure and other sort of abnormalities can persist in those first 6 weeks. After the pregnancy. And then after that, generally you're transitioned back to your usual nephrologist if you were following with someone else during the pregnancy. And just, keeping in mind that those first few months or even years can really, be all about the baby, but making sure that you're also having your regular checkups with your nephrologist, getting back on medications if appropriate, that you were on before pregnancy for your kidney. So thank you so much, and I look forward to having a conversation and answering any questions you may have.
And we're back. Dr. Dubrofsky, thank you so much for that wonderful presentation. Highly informative, covered a lot of vital information. I see that there are a couple questions in the box already. So again, we do encourage you, if you have any questions from the presentation, or you think of them over the next few minutes, be sure to drop them in the Q&A box and we'll gladly address them for you. Dr. Dubrofsky, I know you mentioned on a high level pre-implantation and genetic diagnosis. So I just want to make one quick point. that the PKD Foundation of Canada, as part of last year's summit, did have our Hamilton chapter coordinator, Joy Picard, whose family went through PGD, present on that. So if anyone is looking for kind of a long form conversation and a Q&A related to that, again, check out npkd.ca/webinars, and you will find more information related to IVF and polycystic kidney disease. You mentioned speaking to your nephrologist, your GP, and your OB ahead of pregnancy to make sure that everybody is kept in the loop with the decisions that you're going to make. Can you speak a bit about the timing to that? Because I know for a lot of people, that's the big question, right? When to start having these conversations. Do you have kind of a ballpark that you recommend people begin the dialogue?
Yeah, I mean, I think it's good to start it as early as possible. Even if you're thinking I may want to get pregnant in a year or 2 years, specifically because depending on, the comfort level of your current practitioners, they may want you to speak to somebody else. So there are nephrologists, such as myself and several of my colleagues who do specific like preconception counseling for certain patients. And I don't think every patient needs that necessarily, but it's like a specialist appointment for that, but some do. And there are sometimes wait times for that and things like that. So I think that's one reason to bring it up early. Another reason, some of the blood tests, it takes time to go through them, just the normal blood tests that I think, even people who have no medical problems should have before pregnancy. We want people to be on folic acid for, at least 6 weeks before pregnancy. So all these things take a little bit of planning and time. So I think if you're thinking about it, it's a good idea to talk about it early. And, I try to speak to all my young female patients at every visit who are childbearing about any plans for pregnancy, but I think a lot of that is because I deal with pregnancy. So it may not be on other people's radar the same way. So I think it's a good idea to bring it up.
Okay, thank you for that insight. You spoke a bit about, again, having kind of a multifaceted care team, dietitians to help with weight loss and nutrition management, social workers. You spoke a bit about the postpartum mental health aspect of it. Do you often find that your patients are looking for that social worker or mental health support at the beginning as well, going through the decision process of pregnancy and PKD and the possible genetic component and those avenues?
That's a great question. I don't have a ton of experience with the like I mentioned with you, the pre-implantation genetics and things like that, but I think that's a very complex decision, and for sure a multidisciplinary team is helpful. For patients with more advanced kidney disease, they're hopefully part of a multidisciplinary care clinic and have access to that. So for sure, that's very important.
Okay, you touched on something that isn't often discussed, and that's dialyzing while pregnant. It's not very common. I haven't heard from many patients that have gone through that process. Can you just speak a little bit more related to what that would entail? I mean, it's obviously quite different, heightened management and watching from the practitioner standpoint, but can you just elaborate a bit on what that would entail?
It's I would say it's one of the most it's very hard on patients, I think, but very it's amazing in a way what some patients have done. So my colleague Michelle Adunowicz at Sunnybrook is really one of the world leaders in this, and she was one of the key people to show that if we do really intensify dialysis, so it turns out it's about 36 hours in people who are not making any urine. So if they're making some urine, it can sometimes be less than that. And so usually people, if they're coming to the center, they come 5-6 days a week for prolonged sessions. We have had people doing home hemodialysis, here in Toronto while pregnant. And peritoneal dialysis is not usually recommended during pregnancy. So usually it's hemodialysis, either home or in center, and very prolonged. And it's challenging, and especially, home dialysis, as you can imagine, as a woman's pregnant, they're gaining weight, right? So trying to manage fluid and weight management and knowing how much fluid to take off, but it does work out. The general recommendation is if you have the option to have a transplant before a pregnancy, and if that's an option, to go through that, wait a year until you're stable on transplant medications, go on pregnancy safe medications, and have a pregnancy like that. But that's not an option for everybody, and sometimes time also is not in a woman's favor, and so having a baby on dialysis may be an option. Less frequently is, what potentially comes with more risks is when somebody needs to start dialysis on during a pregnancy because the kidneys have gotten worse. And fortunately, we don't do that. We don't see that frequently, but it does happen.
And so you spoke to the timing between transplantation and pregnancies. Have you experienced individuals that may have come across a pregnancy that didn't necessarily fall in that 1 year after transplant, and what that journey may be like for a PKD patient?
I haven't personally. I think in general, I think the transplant physicians are pretty good. The main thing is that one of the transplant immunosuppressive medications is very teratogenic, so it causes harms in the baby. And unfortunately, it's one of these medicines that actually needs to be stopped prior to pregnancy, like weeks prior. So even exposure of the fetus within 6 weeks of conception would be potentially very dangerous for the fetus. So I think for that reason, the transplant physicians are usually very good at making sure that patients understand that if they're going to get pregnant, they need to be on another medication and this type of thing. So,
excellent, thank you. Okay, we're going to jump into the Q&A box here. We have one question from an attendee that's asking, postpartum, what iron supplement do you recommend if someone has low hemoglobin?
Thank you. I feel amiss that I didn't mention iron, because that's something that we actually deal with a lot in patients with chronic kidney disease who are pregnant, and frankly, patients without chronic kidney disease who are pregnant. We know that iron deficiency in pregnancy is really, really common. The baby basically eats all the iron from mom. And even if it doesn't cause a woman to actually have low hemoglobin or anemia, just having low iron during pregnancy can lead to, feeling unwell or feeling fatigued and things like that. So we do try to be very aggressive with oral iron. And if someone's not tolerating oral iron, then IV iron. For that question, the first thing I'd say is just to, ensure with your physician that the cause of the low hemoglobin is in fact low iron, because there are other causes of low hemoglobin that may need to be addressed, kidney disease being one of them, but other causes as well. If there is low iron, I don't have like a favorite brand. There's different formulations of iron. So there's ferrous gluconate, ferrous sulfate, and ferrous fumarate are the three sort of elemental types. And basically they are similar. It's just that each of those in that order has an increased amount of elemental iron. So you'll absorb more iron from that pill. The problem is the more elemental iron, the more it causes GI upset, so constipation or other GI symptoms. So the trick with iron is really to go slow. Sometimes people need to start every second day. Sometimes you need to start with a more gentle form. When you're taking iron, if you take it with vitamin C, it'll increase absorption. If you take it with calcium, it'll reduce absorption. So taking it with orange juice, but not with a glass of milk, basically. So those would be, but I don't think there's specifically one brand. It's everyone kind of tolerates them differently as well. And if someone really cannot tolerate oral iron and their iron is very low, then sometimes they do need intravenous iron.
Okay, thank you for that. Another question from an attendee tonight. If you're a PKD patient and have had a baby, is there a recommended time they allow their bodies to heal before getting pregnant again? Or is it the same as someone without polycystic kidney disease?
Yeah, I don't have a lot of evidence to guide that. There's a little bit of evidence in people who've had an acute kidney injury. So like the kidney got damaged, not related to polycystic kidney disease, just the kidney got damaged during pregnancy, that waiting 18 months may be better. So if we see people with that specific problem, we do recommend that, understanding that maternal age may mean that they want to try earlier. Even in people who have preeclampsia, there's not really a lot of evidence to support when pregnancy spacing to improve outcomes, other than just trying to improve risk factors between. So I think, getting the clearance for a physician makes sense, but everyone's different. I don't have like a blanket answer.
Thank you. With respect to multiple pregnancies, the risk obviously elevates with the second pregnancy. Can you recommend a few common considerations for someone that's going to have their second or possibly third child that may vary from their first one?
Yeah, I mean, I don't know that the risk increases. So when I said multi-fetal gestation, I meant like twins. So that increases the risk of pregnancy. I don't know that it depends. I mean, if somebody's kidney disease has progressed between pregnancies, then for sure the risk would be higher in the second one. But if that was not the case and the person's medical status is overall stable, I don't think there would be a huge difference. And often, our patients are like pros by the second time. They're telling us what to do. So.
We have time for a couple more questions, so be sure to jump into the Q&A if you do have any outstanding questions or concerns. Samina is asking, she starts by saying, thank you for a wonderful talk. Then asks the question, what is your advice for screening for PKD to the mother and the infant? Do you do immediate renal ultrasound? Also, what is the prevalence of renal stones in the PKD pregnant patient? So a twofold question.
So I'm so sorry. I was actually thinking that this might come up as I was listening to the talk, and I don't do any pediatrics at all, and I don't want to give an uninformed answer. So I'm just not the person to answer that question, like about when children should be screened and how it would change management. I'm just going to defer that. I apologize. In terms of stones, yeah. So it's a good question. So as patients with polycystic disease are at an increased risk of stones. Stones in pregnancy can be a bit challenging in terms of diagnosis and things like that, but the same general recommendations for stone prevention would have a role. And stones usually develop over time, so unlikely to develop new in a relatively short 9-month period, but certainly possible. But stones can often be diagnosed with ultrasound in the acute phase, so that's what we would generally do in a pregnant patient.
For anyone that is interested, Dr. Langtree, who joined us last week, did go in long form on the genetics of PKD and spoke to the timing and considerations surrounding screening your infants. So be sure you get that recording for his input and feedback. And of course, take that into consideration when speaking to your medical providers, caregivers as well. If there's not any more last questions to be asked, there's one coming up. Thank you for the hope you give. When I was diagnosed at 33, I say goodbye to a nephrologist to forget having kids. So that's more of a comment from Priscilla. Dr. Dubrofsky, thank you so much for your time this evening, for joining us. It's been very educational for myself and for those in attendance. And we really appreciate you making the time to join us tonight.
Thank you so much. It's great to be here.
Okay, we'll talk to you soon.
Thanks.